Hello and welcome to another episode of Cracking Addiction with Philippe Naren and Fergal Armstrong. In the episode of Cracking Addiction today, we're going to go slightly philosophical, and Fergal, I'm going to ask you a bit of a leading question. What is addiction medicine and how does it differ from primary care or general practice? Is there a difference?
Is there a difference? Well, I think there's a significant overlap. And I think there are a lot of GPs who have got a significant expertise in the community management of substance use disorders and addictions. But addiction medicine is a known, recognized specialty within the Australian medical framework. And addiction medicine specialists do operate both in the community, like GPs, but also in hospitals, and they actually work very well in hospital settings. So I think there is a significant overlap in their roles, but they do have specific, unique tasks. So, I mean, if we look at addiction medicine specialists and their hospital practice, a lot of it is to do with consultation liaison and also inpatient detoxes. And I think those two things separate out what addiction medicine does uniquely away from that combined pool of activity that both addiction medicine specialists and GPs do. So I think we need to identify or describe the management of inpatient detoxes and also what consultation liaison is firstly. Mm-hmm. So Philippe, what is consultation liaison?
So consultation liaison from an addiction medicine perspective is when patients are referred to the addiction medicine service, usually by their home unit or their treating team, for addiction medicine related problems. A lot of patients will present to the emergency department or be admitted to the ward for a number of medical or surgical conditions. And incidentally, sometimes they are found to have substance use disorders, or they develop complications related to withdrawing of substances or multiple substances, and addiction medicine are referred to them or offered support via addiction medicine to manage some of these complications of withdrawal. Sometimes we're also proactively seeing patients on the ward who've been flagged by their team or ED as potentially having a substance use disorder as well, and trying to engage with the patient. In summary, what consultation liaison is advocating for the patient, supporting patients with substance use disorders during their hospital admission, making sure they're receiving evidence-based care, whether that be opioid substitution therapy or the appropriate medical management of withdrawals. And that's, I guess, consultation liaison in a nutshell, trying to engage patients and keep them engaged in treatment. And it can be quite a difficult and stressful field at times, just because a lot of the times when patients are admitted to hospital, it's not for their substance use disorder or their substance related issues. And trying to keep the patient engaged and in hospital is, I find, the most challenging aspect of consultation liaison. Would you agree with that, Fergal?
Absolutely. I agree with everything that you've said. So when you think about the prevalence of substance use disorder in the community, right? So for instance, methamphetamine use disorder, cannabis, I think, is the commonest substance that is used in the community. And then methamphetamine and heroin and prescription opioids are kind of next in line. When you think about how many people have a substance problem, then theoretically, any ward would have that same percentage of people affected. So, I think roughly more than 10% of the population have used cannabis in their life, and also think about the prevalence of smoking. So, roughly about 16% of people smoke. So, it's no different from managing someone who's having cravings from tobacco compared to cravings from heroin or cravings from methamphetamine or cravings for cannabis. So, we have to expect that substance use disorder is represented in hospitals at least to the same level as it is represented in the community. And in fact, Because of the significant comorbidity associated with the substance use disorder, actually the prevalence is higher. So what kind of medical problems would you commonly see, in your role as providing consultation liaison?
So I like to break it up into the surgical and the medical. So a lot of the time we see patients, say post-trauma, sometimes under the orthopedic unit for the variety of broken limbs, and sometimes under the general surgical team with, say, acute pancreatitis, abdominal issues. And the issues that we sometimes have to deal with there are, say, for example, patients with opioid use disorder, where we've got patients where we have to maintain them on their opioid substitution therapy if they are on that in the community, or if they are not on that and, say, using heroin or non-prescribed opioids, maybe initiating opioid substitution therapy. But then also providing advice on pain management for patients who have got a significant tolerance for opioids. And sometimes people in the hospital view opioid substitution therapy as pain management rather than what it is, which is trying to stabilize an opioid use disorder. So sometimes our role is very much to advocate for the patient, and sometimes to encourage increased opioid prescribing to make sure the patient's needs are being met. So
exactly, yeah.
That is,
there is a common myth. There is a common myth, isn't there, that if you're on opioid substitution therapy when you go into hospital, you don't need additional opioids for any nociceptive pain that you've got. And that's just not true. And I suppose you're right, one of our roles is to actually advocate for patients in that regard and help them and manage their pain as they're in hospital.
Indeed. And sometimes also our role is also to assist with, say, deprescribing. Sometimes we have patients who come in quite sedated, say, for example, if they've got pneumonia and they're on a variety of different, say, opioid medications, benzodiazepines, gabapentinoids. And sometimes our role is to try and titrate the medications down to get to a safe level. Or when patients have repeated hospital presentations for similar events of sedation or being, say, narcotized, our role is to try and get that safe balance of medications where the patient's needs again are being met, but overall safety is also being maintained as well. So sometimes it's about prescribing some medications, other times it's about deprescribing. And the governing principle is that of safety, but also trying to make sure the patient is treated in a fair, equitable, and humane manner.
Yeah, you alluded to the difficulties of keeping patients in hospital. I mean, could you comment about that a bit more?
So the thing with hospitals for a lot of the patients that we see, especially patients with substance use disorder who may have been in hospital before, a lot of our patients are used to being treated poorly, to being stigmatized, to being judged, to not being listened to, and to having, say, their pain needs not met or their requests for analgesia not listened to at all. So a lot of patients have very negative experiences of hospitals, of doctors, of other healthcare practitioners. And in a setting like this, which is quite stressful, you further try and put on another layer of stress to a patient where, for example, in a previous episode of Cracking Addiction, we talked about people using drugs in hospitals. And I'm kind of talking about that in this scenario where people use drugs for a variety of reasons, but one of them is to self-soothe and as a coping mechanism, as a stress reduction mechanism. So our role in addiction medicine is to advocate for our patients and to keep people in hospital. Sometimes some patients leave hospital to use drugs to help modulate their stress response. And essentially, sometimes from a harm reduction point of view, if we can keep people engaged in healthcare, make sure their underlying life-threatening health condition can be treated, I guess our role is to try and advocate for the patient and try and make sure that they use substances in as safe a manner as possible if we can keep that engagement. So I guess the consultation liaison program is there to make sure we try and best meet people's needs and also treat the patient where they're at in their journey with substance use disorder. So I think that in a nutshell.
Would that involve additional benzodiazepines and opioids? But more so than you would otherwise prescribe?
Sometimes, depending on the clinical scenario. So as with anything, you have to have a reason for why you prescribe medications. And you also have to have a clear starting plan, but also weaning and cessation plan. Doing anything without an exit plan or a rationale is going to lead to disaster and tears. In particular, with benzodiazepines, for withdrawal clearly indicated, sometimes for agitation and behavior management, it can certainly be utilized for a while. But usually while people are in their inpatient stay, we would be having a discussion with the patient about weaning and ceasing that, particularly if they were not on that prior to coming into hospital, because you don't want to kind of create more iatrogenic dependencies for the patient post-discharge than when they entered. And that's also in that harm minimization framework. Is that your approach as well, Fergal?
Yeah, every case has to be judged on its merits. But I think the philosophy is absolutely the foundation upon which we operate. And that philosophy is we are patient advocates, and we are there to provide best practice, and we're there to dispel the myths, and we're there to intervene when required. And when I think about some of the complex cases I've dealt with, heroin use disorder presenting as a spinal abscess in a neurosurgical ward, or someone with endocarditis threatening to abscond, or someone who's had an appendectomy and they're terrible pain. They shouldn't be in that much pain. And so therefore I've had to intervene when other doctors have said, "Oh, that patient's just faking it." I said, "Well, they're not faking it. They've got a heroin use disorder. They're opioid tolerant, therefore they need more opioids." So this is a kind of range of problems that we do, that we manage. So, we've talked about what CL is. How would you define inpatient management of withdrawal? What's that all about?
So I guess as per the heading and the title, the inpatient management of withdrawal is the opposite of a home-based management of withdrawal.
So this is inpatient management of withdrawal.
So this is when patients get admitted to the withdrawal unit, and we try and medically manage their withdrawal symptoms. And the hallmark of this is probably using combinations of medications and doses of medications far in excess than what you would do for home-based withdrawal. And in particular, if we're talking about diazepam, I think we've talked about fixed dose withdrawal guidelines in GP land, and usually that would probably be, say, on day one. At a maximum, we're probably talking about 10 to 15 milligrams QID. For inpatient management of withdrawal, I've given doses of diazepam approaching, and I'm not saying we do this routinely, but approaching 200 milligrams. Usually 100 milligrams would not be out of the question. And
that wouldn't be unusual.
No, and we're also dealing with patients who are medically unstable and where a home-based withdrawal would be quite dangerous. So you're dealing with both substance use that is quite high, but also patients whose health situation is quite precarious and could deteriorate quite quickly. So you're there to both manage the withdrawal, but also potentially try and manage other complications such as delirium or decompensated heart disease or a flare-up of liver disease. So that's inpatient withdrawal management in a nutshell.
So I think I would add to that not only is it just about increased amounts of withdrawal medication, it's also about close monitoring. The monitoring is the key thing that can happen in an inpatient unit that doesn't happen in the community. You cannot get intensive monitoring in the community.
Absolutely.
Would you agree with that?
I would, and you can also respond to deteriorations far quicker because of that monitoring as well. So I think the difference between the two, if you had to say it, is not only the medications and the doses, but it's also the risk profile of patients that we're dealing with as well, and the fact that you have basically to be eligible for a home-based withdrawal, you have to clear quite a few hurdles to be deemed medically stable and medically suitable. We don't necessarily have to clear those barriers or those bars for inpatient withdrawal management.
Yeah. So we've talked about the two key functions that an addiction medicine specialist does in hospital. What do GPs and addiction medicine specialists do similarly in the community? What would you say to that?
I think the things we do similarly, and I think we're in the position where we can speak as both, or you certainly can speak as both, and I will hopefully one day become an addiction medicine specialist as well. But essentially what we do in the community is the same thing. We engage with patients. We meet the patients where they're at. We try and start patients on therapy we feel that will improve their life and increase their longevity and decrease complications. We try and treat the patient as a complete individual. We not only try and deal with their substance use disorder, but also try and manage cardiovascular disease, liver dysfunction, treat any bloodborne viruses, manage any STIs, provide education on harm minimization and harm reduction strategies, and try and provide the appropriate psychosocial interventions. So we do a lot of things that are very similar, but there are a few differences between general practitioners and addiction medicine specialists. And that's also a function of sometimes where we work and the resources we have available also. So, yes, but we do very much walk hand in hand in the community, and I guess we should, and the relationship should be a synergistic one where we feed off each other.
Yeah, I would characterize the role of an addiction medicine specialist in the community as being fourfold, really. So, the management and oversight of community-based detoxes, because, they still do exist. I know we harp on about how dangerous our detoxes are, but there's a huge number of community detoxes that happen every day. So that's one. Secondly, relapse prevention. I think we do a lot of relapse prevention work, both with medication and psychological interventions and therapies. Then we do harm minimization, and then we manage comorbidities. So, as you've already mentioned, we look at heart disease, we look at lung disease, we look at liver disease. But I think this is one of the differences between addiction medicine specialists and general practitioners, because I don't believe that addiction medicine specialists manage quite the range of comorbidities that GPs do. And I think that GPs are experts in the management of the whole patient, the management of comorbidities, and also, harm minimization and relapse prevention and community-based detoxes. I think, GPs could do that entire range. And I don't believe that all addiction medicine specialists are going to be able to manage somebody's asthma, someone's hypertension, someone's ischemic heart disease, someone's stroke secondary prevention, someone's, dysmenorrhea, these kind of things. So that's where I think the border is between addiction medicine specialists working in the community and general practitioners. What would you say to that?
I'd agree totally. It's a function of general practice to view the patient holistically and try and treat all the conditions, and there's no one organ system that a general practitioner looks after. It is the whole person and the whole body, and it is a very, very challenging specialty, general practice. To be a good general practitioner is exceptionally difficult, and I think you and I are fortunate, Fergal, in that we have a lot of great colleagues out there who are fantastic general practitioners and who also, in amidst treating all the things that general practice involves, also do a great job with substance use disorders and addiction medicine. But then again, that's also just part of that holistic care of the patient that is part of general practice.
Yeah, you're absolutely right. We are very lucky that there is a very high standard of general practice in Australia. I think it's a world-beating standard of practice. And certainly when I came from the United Kingdom to Australia, I was very impressed with the standard of general practice. Here's a tricky question for you. If you had an issue with an addiction, and would you phone a GP or would you get a referral to an addiction medicine specialist? And what decides that for you?
I would go to my GP, actually. Mainly because I think your GP should be your first point of call in general. And a lot of GPs can manage addiction medicine quite well. I don't think every single issue related to substance use disorder or addiction automatically needs an addiction medicine specialist referral, particularly if it can be managed in the community adequately by the same person that looks after your healthcare. Substance use disorder is part of healthcare, and by default, general practitioners should be managing the vast majority. If there's a specific need to see an addiction medicine specialist, and that would potentially be if the patient needs a inpatient withdrawal admission or a hospital admission, or there's some complexity that is beyond the expertise of the general practitioner, then that's fair enough. But as a starting point, I think seeing your general practitioner and seeing if they can manage it, which they should be able to, I think that's a good place to start. Would you agree with that? Yeah,
absolutely. I think the general practice is more than capable of managing the vast majority of addiction issues. It's only the more complex stuff that really needs to go to hospital. And especially, I think it's important for people to realize that within primary care, we have the ability to treat opioid use disorder, for instance, incredibly well. I mean, that domain of opioid use disorder has really been transformed by the advent of certain kinds of drugs. Would you care to talk about that, Philippe?
Sure. So with opioid use disorder, the preparations we use are essentially buprenorphine and methadone. And with buprenorphine, we have Suboxone, but we also have the long-acting injectable preparations, Buvidal and Sublocade. And we have talked about all of these on earlier episodes of Cracking Addiction, if anyone would care to look at those episodes in particular. But all of these are available through primary care. You certainly do not need to see an addiction medicine specialist to access opioid substitution therapy. And also these can be dispensed through community pharmacies. So you definitely don't need to go through a hospital pharmacy for any of these drugs at all. So this is well within the wheelhouse of primary care, as it should be.
And also too in the case of alcohol, there's an established protocol for non-residential withdrawal from alcohol, which actually Medheads has published. But it's entirely reasonable to have a home-based alcohol detox, managed by your GP and maybe a community-based AOD counsellor, and also the responsible adult at home. I mean, have you got any stories to tell about effective, safe management of NRWA?
Yes. For the vast majority of patients I saw initially when I was working in regional Victoria, we didn't have access to as ready access to residential facilities as we do here in Melbourne. And also for a lot of the patients I was seeing, their overall health status was relatively good. So I was privileged enough to work at a health service where we had drug and alcohol counsellors embedded within the service, and there was a significant amount of monitoring where I could manage a lot of the withdrawal symptoms on an outpatient basis with staged dispensing of medication through a variety of different services, and also ability to get the patient in, as well as including transport to bring the patient to and from the clinic. So I've had quite a bit of experience in the community of doing a variety of withdrawal regimens, including alcohol, but also cannabis. And it's with appropriate patient selection and appropriate supports, it usually goes relatively well, and it's it's quite rewarding, and it certainly spares the patient a hospital admission or inpatient withdrawal management admission. So it's a good use of resources as well.
So really, a good GP in the community probably does a better job of managing the patient holistically than an addiction medicine specialist.
Indeed. And I think that's probably a good place to end this episode of Cracking Addiction, where we've talked a bit about the differences between primary care and general practice and addiction medicine, what an addiction medicine specialist does in hospital and in inpatient withdrawal units, and also how both addiction medicine specialists and GPs work in the community, and how this can actually be a synergistic relationship, and how GPs should be the first port of call for patients with substance use disorders. So thank you for your attention on this episode of Cracking Addiction, and bye for now.